Okay, so yesterday we've heard Rosalind Watts talk about the therapy program that's currently being used in London in the psilocybin for depression study. And we've heard that acceptance is apparently one of the core mechanisms underlying the efficacy of psychedelic therapy. And the interesting question is, of course, how does that work? How does psychedelic therapy promote acceptance? And I would like to try today and give a preliminary answer to that question. And I'm going to do that from the perspective of cognitive behavioral therapy. Now, I'd like to start by defining the terms avoidance and acceptance. So, first of all, avoidance in a colloquial sense does not mean anything pathological. So if you have, for instance, successfully avoided to get hit by a truck on the way here or something like that, then there's no reason to worry about that. But when I talk about avoidance today, I always mean pathological forms of avoidance. This is defined as the attempt to evade, escape, or otherwise alter one's experiences, such as emotions, thoughts, memories, sensations, etc., despite harmful consequences. Imagine you're not leaving the house at all in order to avoid feeling anxious. Or imagine ruminating for many hours a day in order to get rid of negative thoughts or negative feelings. Or imagine you want to quit smoking and you just cannot because that would mean feeling irritable for quite some time. Now that is the kind of avoidance that we're talking about here, avoidance that has negative consequences. Now, acceptance means just the opposite of that. Acceptance means the ability to allow one's experiences to unfold without controlling them. As you have seen, avoidance is really a transdiagnostic feature of mental disorders. It does not only occur in anxiety disorders, but it occurs also in depression, in substance use disorders, and many more. And accordingly, psychotherapy and especially cognitive behavioral therapy would always try to reduce patterns of excessive avoidance and promote acceptance. Now, the problem with that is that in the patients that we see, the patterns of avoidance that they exhibit, they're often very hard to change, very rigid. And that is because these patients are often sort of trapped in a kind of vicious circle that keeps the avoidance alive. So at the cognitive level, we commonly find these very rigid avoidance-related beliefs. Imagine having beliefs like, being emotional is a sign of weakness, or boys don't cry, or perhaps something like, if I get very sad, I will collapse and break down. Now, if you have beliefs like that, then sadness becomes a very scary thing, doesn't it? Something you really have to avoid. Now, imagine you have beliefs like that, and then you are in a situation where you're being reminded of something painful, something that makes you sad. What will you do? Well, probably you will engage in some sort of avoidance behavior. Perhaps you will try and distract yourself or suppress the feeling, or maybe you will even drink a bottle of wine, and to numb the feeling. And the problem with that is that these kinds of avoidance behaviors will often actually work, at least in the very short term, in the sense of you drink your bottle of wine and suddenly you don't feel so sad and scared anymore. Now that is operant conditioning, yeah? The avoidance behavior is immediately rewarded, negatively reinforced, and that's what makes the avoidance behavior more likely to occur in future situations. And when this is repeated many times, then avoidance can even become completely automatic. And this is something that we see a lot in patients, automatic avoidance due to operant conditioning. Now, once avoidance has become the standard response, then this is a big problem because then there is no possibility to have novel experiences, corrective experiences that would challenge those rigid avoidance-related beliefs. Imagine every time you start feeling sad, you have a bottle of wine. Then you cannot possibly find out that sadness is not such a bad thing, that it will come and go, yeah? And that it will certainly not make you break down or collapse or anything like that. So this is the vicious circle of avoidance. This is why patients stick to avoidance, although it hurts them on the long term. Now, cognitive behavioral therapy would always try to reduce avoidance and promote acceptance by trying to break this vicious circle. And we try to do this by intervening at the different levels. So at the cognitive level, we would always try to achieve a revision of avoidance-related beliefs. Or you could also say detachment from avoidance-related beliefs. So there's a lot of different CBT interventions available for that. We can do classical disputation via Socratic dialogue, but there's also tons of diffusion exercises, decentering, behavioral experiments. There's really a lot of CBT interventions for doing that. At the motivational level, remember the problem was conditioning of avoidance, so we have to counteract that. We have to build motivation for acceptance instead of avoidance. And this is, of course, mostly done indirectly via the revision of avoidance-related beliefs. But we can also try and tackle motivation directly by helping the patient become aware of the cost-benefit ratio of their avoidance agendas. And we can do this by, motivational interviewing and techniques like that. And at the behavioral level, the patient needs novel experiences to challenge these avoidance-related beliefs. And so we have to help them expose themselves to otherwise avoided experiences, yeah, and help them also desist from avoidance behaviors while doing this exposure. And the best example for that is, of course, exposure treatment of anxiety disorders. But we don't use only exposure only for anxiety disorders, but we also expose our patients not only to fear, but also to all other kinds of emotions, to thoughts, to memories, to physical sensations. And if you think about it, then really most CBT interventions have some element of exposure in them. If you think of behavioral experiments, there's always exposure in that. Or role play, there's always exposure in that. Or mindfulness practice, which is commonly being incorporated into CBT. That's also, if you think about it, that's really a kind of a broadband exposure to one's inner stream of experiences. And, even just talking to a patient about something that they would usually avoid talking about, that can already be a kind of in sensu exposure. So this is what CBT does in order to promote acceptance. And now, for the rest of this talk, I'd like to convince you that psychedelic therapy does in fact do something very similar. Yeah? So we will eventually come back to this model here. Now, psychedelic therapy, let me just briefly define that for you, although most of you probably know what it is. So psychedelic therapy refers to a treatment of mental disorders where patients are dosed with high doses of serotonergic psychedelics. There's usually only between 1, 2, or 3 dosing sessions. The whole thing takes place in a very controlled setting, and the kind of psychedelic therapy that I'm talking about today always takes place in a professional clinical context. This is something that I've said before in the panel. So the patient is lying down here. The guides are sitting there. It looks like the patient is not behaving, but people always behave, and especially in psychedelic therapy, there is a lot of internal behavior going on. I'll come back to that in a bit. So regarding efficacy, psychedelic therapy, there are some small-scale modern studies. You all know these studies. They're very encouraging. I don't have to go into detail about these studies, but what is important is that all of these mental health conditions where psychedelic therapy appears to be quite effective are arguably characterized by high levels of experiential avoidance. In some of those studies, the researchers have made the effort and conducted qualitative interviews with patients. And these interviews are really tremendously important because they provide us with clues about what's going on in these therapies, and they provide us with information about the potential mechanisms underlying the efficacy of psychedelic therapy. And what's interesting is that avoidance and acceptance are very common themes in these interviews. So if you read these studies, you're going to find a lot of examples of patients talking about psychedelic experiences in psychedelic therapy where they were avoiding things or where they were found ways to accept things. And you will also find a lot of examples of patients transitioning from patterns of avoidance to acceptance through psychedelic therapy. Here's just one example of that. So this is a patient from London who was treated with psilocybin for depression. And this patient is saying, I have felt a sense of acceptance, more acceptance of agony, boredom, loneliness, and also appreciation of the wonderful times, a willingness to try and accept the negative times. Now, in this one, it's really quite explicit that for this patient, apparently acceptance was one of the ways in which the therapy helped them. And the interesting question is, how is it possible? How did psychedelic therapy promote acceptance in this case? So here we're coming back to our CBT model, and I'd like to start by asking, how could psychedelic therapy possibly help with the revision of avoidance-related beliefs? Well, if you look at current theories of acute psychedelic drug effects, then it turns out that psychedelics are really all about reducing the confidence in one's beliefs. This is called the principle of belief relaxation. I'm not going to go into psychopharmacological details now, but what is important is that belief relaxation can really explain the whole spectrum of acute psychedelic drug effects, and this is simply because it affects all kinds of explicit and implicit beliefs about the world and oneself. And this includes, of course, avoidance-related beliefs of the kind that we've seen in the beginning. Now, when these beliefs become relaxed under psychedelics, this means that they sort of open up towards novel information that is otherwise ignored or suppressed or explained away. And this leads to a situation where one is much more easily surprised, surprised in the sense of finding out that one's beliefs have been wrong and need to be updated. And this kind of psychedelic-induced insight can in fact lead to long-term changes in beliefs. And this is belief revision of the kind that is needed with regard to these avoidance-related beliefs. Let me show you just one example. This is from Rosalind's study from London again. So this is a patient who apparently realized something about their previous beliefs. I saw that it's not a weakness to be emotional. That's an unhealthy attitude. Now, this is obviously a very positive example of psychedelic-induced belief revision. And here it becomes interesting because I assume this is quite a typical example. Why do we mostly see positive outcomes of belief revision? Why don't we much more often see, patients coming out of psychedelic therapy and having much worse avoidance-related beliefs? And my answer to that would be that psychedelic therapy does not only relax avoidance-related beliefs, but it also builds motivation for acceptance and, at the same time, provides some fantastic exposure therapy. And that all together kind of creates the context in which beneficial belief revision can take place. Well, what about motivation for acceptance? Now, remember, the problem was that under normal circumstances, avoidance behaviors are often immediately rewarded. There is conditioning of avoidance. Now, my idea is that in the psychedelic therapy, this can be essentially turned around, in the sense that avoidance is not rewarded, but avoidance is now punished. Let me try and explain this. So, belief relaxation at high levels, as is the case in psychedelic therapy, would always lead to an increased context sensitivity throughout the system. So, for instance, you would get something, like visual processes becoming sensitive to auditory processes that are going on at the same time, and then we get something like visual auditory synesthesia, where patients start seeing the music that they're listening to as a kind of a landscape or something like that. And synesthesia is, of course, an example for context sensitivity within perception or across perceptual domains. But context sensitivity also refers to a sensitivity, of course, to the affective and motivational context. So, due to this context sensitivity, an avoidance state or an avoidance set will always very likely lead to the emergence of avoidance-related perceptual content. And this will always be, or most likely be, something aversive. So when you start avoiding something in psychedelic therapy, then you're likely making the experience worse, more aversive, not less aversive. So this is conditioning of acceptance in the sense that the more you avoid, the more you get punished, and the less you, or the more you manage to desist from avoidance, the less you get punished. So there might actually be something like shaping going on, shaping of acceptance in psychedelic therapy. Here's another quote from the London study. This is a patient talking retrospectively about their psilocybin experience. There was this huge, terrifying creature with a rifle, and instead of running away, I looked at it, and it wasn't as scary as it had seemed. If I had avoided it, it would have got more terrifying. Now, I really like this quote. I think this is a really great illustration of conditioning of acceptance in psychedelic therapy. So this patient has apparently learned during this session, probably, that in this particular state, in this psychedelic state, and in this setting, avoidance is punished. So he decides to, or she decides to turn towards the aversive stimulus and not away from it. So now we have a situation where avoidance-related beliefs are relaxed and sort of kind of ready for surprise. And at the same time, we have a patient who is very motivated for acceptance. Now, from a CBT perspective, this is just an ideal moment for some exposure treatment, isn't it? And there's good reasons to believe that psychedelic therapy provides some fantastic exposure treatment, and this is simply because psychedelic states go along with the intensification and elicitation of such a fantastic, great range of internal experiences, not only emotions, but also thoughts, autobiographical memories, physical sensations. I believe embodiment, what Rosalind talked about yesterday, is a very important aspect of exposition, exposure in psychedelic therapy. We know that music plays a very important role in especially evoking and modulating emotions in psychedelic therapy. And probably this setting, so this introspective setting where people are wearing eye shades and the sort of perceptual environment is very, very undefined, very uncertain, will also play an important role in helping the patient look inside, be introspective, and having very intense internal experiences. And although it may sound trivial, but I think the long duration of the dosing sessions, which is like 6 hours in the case of psilocybin, is also a very important aspect of exposure, because it allows for repetition and variation of exposure episodes. And we know that repetition and variation are very important in exposure treatments. Here's another patient. This is a patient from Switzerland who was treated with LSD for anxiety associated with terminal illness. I was very, very sad. I cried, never desperate, but a lot of sad things came up, and that resolved later on and became lightness. I went through heaviness and sadness, but I felt all emotions very intensely. I think this is a very great illustration of exposure therapy that can happen in psychedelic therapy. So here's the whole model. In the middle, we have this common acceptance-promoting learning process that is also targeted by CBT interventions. And the arrows around, they represent psychedelic therapy specific factors. So this is really supposed to show that psychedelic therapy and CBT work, at least when it comes to this acceptance-promoting aspect, they work very similarly. And psychedelic therapy can be very well understood from the perspective of psychedelic therapy. We need to validate this model. So right now we're thinking about constructing a questionnaire, an instrument to measure these three aspects of acceptance promotion in psychedelic therapy separately. And that could also help in identifying obstacles, identifying reasons why some patients do not reach this acceptance promotion in psychedelic therapy. Here's already the summary. So we've seen that avoidance is a transdiagnostic feature of mental disorders. We've seen that psychedelic therapy appears to help with different mental disorders, also cutting across diagnostic boundaries. Qualitative studies suggest psychedelic therapy works by promoting acceptance. And I've shown you this model according to which psychedelic therapy promotes acceptance via the relaxation of avoidance-related beliefs, conditioning of acceptance, and the elicitation and intensification of internal experiences. Well, this model is supposed to show that psychedelic therapy and CBT have some very great synergies, and that psychedelic therapy can be understood from a perspective of cognitive behavioral therapy. I'd like to end with another patient quote. Sorry, Ross, by the way, for stealing all of these. It's just that we haven't done our own study yet. So next time I'm going to use some of my own quotes here. So this patient says, when you take the capsules, and this is the psilocybin capsules, it's like taking on board your own psychotherapist. And well, perhaps we can discuss now whether or not this inner psychotherapist is at least sometimes a cognitive behavioral therapist. Thank you very much.
Thank you very much, Max Wolff. So we take your questions. So you're the first one, yeah?
Hi, thank you. So just one question about the relationship between a state of avoidance and a state of strong attachment to a state of comfort or well-being. Mm-hmm. In other words, is the psychedelic experience dissolving the avoidance or dissolving the strong attachment that we may have?
Can you elaborate on what's the difference between those two in your opinion? Or
yeah, so the relationship between the state of avoidance or the state of a strong attachment. Are there, in your opinion, are there a different state? Are there similar states?
Well, I think they are similar states because I think attachment is sort of the opposite, right? A very strong state of acceptance can also be seen as a state of avoiding to let go of something, you know. So I think this model would also actually apply to this problem, to increased or excessive attachment. I think those are just two sides of the same coin. Yeah.
Okay. Next question. Yeah, please.
Yeah, thank you for your interesting talk. My question is, how do you guarantee that a client attributes this possible adversive states during his psychedelic experience to his avoidant-related beliefs and not to the psychedelic or possibly the therapeutic?
Thank you. That's a very good question. I do not think that the patient should or needs to attribute negative experiences, challenging experiences to their avoidance-related beliefs. I do believe that they should be able to learn, in many cases, that these stages come not from necessarily from beliefs, but from their actions, from their behavior in this therapy session. So I believe if a patient, engages in internal avoidance, like by, let's say, suppressing certain things, looking away from things, moving away from things, and from maybe ruminating or worrying, at some point they will notice that as long as they keep doing it, it all gets worse. So this is actually the conditioning that I'm talking about. And once they maybe stop doing it, then they will perhaps immediately sense like a nuanced decrease of aversion. This is what I mean by shaping of acceptance.
So you mean it's not to directly tackle the avoidance-related beliefs? It is more like learning a tool for handling a situation like that?
Well, I believe it is learning to assume an accepting state in that moment, and that then subsequently allows you to face all kinds of things you would otherwise avoid. And that, in turn, will help you change your beliefs. Then, in that state, you can find out, oh, I'm experiencing sadness, and it's not so bad, And actually, it can be even a positive thing. So that's the moment where I believe that avoidance-related beliefs regarding, for example, sadness could be changed in a therapeutically beneficial way.
So thank you, Max. A brief question: could avoidance be learned? Could avoidance be learned in a psychedelic experience?
Yes, I think certainly it can be. I think that's one of the things that psychedelic therapy needs to take care of, to create an environment where that is less likely. Nonetheless, I believe that even in psychedelic therapy it can happen. There is an interesting study from Teresa Carbonaro, I think, together with Matt Johnson. They did a survey and they found that challenging psychedelic experiences predict long-term well-being. But the twist is that the more intensive a challenging experience is, the better the people were feeling long-term. So the worse their experience, you could say, the better it is for their long-term outcomes. But at the same time, the duration of the challenging experience predicted a worse outcome. So this can be interpreted in a way that if the person has a very long challenging experience and perhaps they do not undergo this learning process and they do not manage to build enough motivation for acceptance, then in the end it could actually make avoidance-related beliefs worse. Yeah.
Thank you.